Kia ora koutou, no mai, haere mai. I think I'll start and then we may have a few more joining us, but we only have an hour, so I'll move in to our opening karakia. Good evening. Tutawa mai I runga, tutawa mai I raro. Tutawa mai I waho, tutawa mai I roto. Kia tau ai, te mauri tu, te mauri ora. Ki te katoa, huimie, huie, tai kie. Good evening, everyone. Ko Mel Juer toko ingoa. I'm the Healthcare Home and Digital Workstream Program Director at Collaborative Aotearoa. Real warm welcome this evening. So many of you to a very topical subject, managing acute demand in general practice. And I'd like to extend a welcome to our speakers, Andrew Miller and Iain Watkins, both colleagues from Te Tai Tokerau, so it'd be great to be sharing our kōrero from that part of the world. I'd like to welcome you all, especially those of you who've had long days in general practice or in other parts of the health system. There's a lot going on tonight, you know, at the moment, and great to have you here. I'm just going to briefly let Andrew and Iain introduce themselves, and then I'll go into the run plan. Andrew, do you want to?
Kia ora koutou. Andrew Miller, a GP in Whangarei. I'm the Healthcare Homes lead for Collaborative Aotearoa. I've also been rolling out Healthcare Homes work in Northland, and practice up in Northland has been Healthcare Home for the last 5 years, and we've been in triage for the last 5 years. So glad to see you all.
Ngā mihi, Andrew. Iain.
Kia ora, Iain Watkins. I'm a practice manager at West End Medical Centre. And also a co-owner. We're a medium-sized practice. We've been in neighbourhood healthcare homes for years. I was just trying to add it up and I can't remember because it's so far back in the distant past.
2016 we met each other.
2016, okay, 8 years we've been in it, if my maths is right. Yeah, so we've had interesting experiences with triage. I'll be talking about that tonight. We're just a medium-sized practice, so it's sort of looking at triage in a small practice.
Exactly, thank you. And Iain has reminded me that's exactly the idea tonight, that we talk about it from a bigger, very busy practice, and Bushroad's a great example. I've just come from 3 years working in 2 whangarei practices who also have quite a high population and high needs, proportion. So we can look at it from that point of view. And sometimes there are smaller practices that say we're too small to do this. And that's why it's be really interesting to hear from Iain how that worked for you. We've got a popular way of joining or sharing stories these days that's growing with the collaborative, and that is an on the couch series, and Iain brings that beautifully to us tonight. And what we're going to be doing is getting through a lot of material and trying to do it in such a way that there's time for questions as well. So I'm going to stop sharing so that Andrew can share his presentation and let him take over.
Can you hope you can see that, Mel? All good? So the little picture here is really probably what our practice looked like even before COVID arrived and even before we started healthcare homes work. We were really basically inundated with urgent and unplanned care. We wouldn't be able to get through the back door at the practice without people asking us for advice around people looking for care that day. We were fully booked with extras, and those who use MedTech would know what a yellow day book looks like, but we were just yellow all day. And it was doing our heads in. So when we started the healthcare homes work, we were already in a bit of a pickle. And what we've done, I believe, with both our processes with clinical triage and with using patient portals, put the place back on track. Also, I guess from my point of view, around the time of started the portal work, I got pretty crook. I was away from work for 16 months, and I found out what it was like myself by having no portal or triage available, had no access to my results, no way to message my practice, had no shared care plan, no advanced care plan. Certainly makes you sharpen your focus around what things might look like. And I certainly, when I came back to work, felt a sense of responsibility, to provide the things that I would want for myself and my own family. And I think it's really has been a silver lining that I've now had to look at things differently. And the things we're doing I really know what it's like to be on the pointy and probably dare I say, the other side of the health system. So I'm going to talk about phone triage, the why we do it, the how we do it, and what's in it for me. I guess also what's in it for the people we look after. So one of the first things, I guess, it values people's time. If they don't have to come in and can be sorted out in 3 minutes over the phone, rather than driving for half an hour, sitting to see you and drive home, that has to be something that's good for the people we look after. It also gives them another way of getting care, other than just coming in and getting a face-to-face appointment. It's really efficient for business, which for a bunch of reasons, in terms of seeing the people that need to be seen and not overutilising or diluting capitation. It has helped us deal with acute demand. It's freed, I should say, it freed up proactive and planned care time, but actually at the moment with COVID, with the demands and a number of staff away, it's just keeping us treading water with our head above water at the moment. So for many of us, proactive and planned care has drifted backwards, which I think in the long run might be quite detrimental to a lot of people in the country. And it gives people a choice they didn't have before, which I mentioned when I was sitting on the wrong end of the equation. Also, I think too, these are some other things just off the top of my head. We had to do this 6 or 7 years ago when we started this work at my practice, because we had a burning platform and we needed to douse it. We were not coping with the number of people seeking same-day care. It was just out of hand. It also then, I think, has given us much better clinical outcomes. We're able to, after a conversation, book someone in with the right person for the right length of time. So someone might need a half an hour because they've got a mental health issue, or they might need something like a pelvic exam that is going to take a bit longer, or it might be a complicated assessment that might end up with a admission to hospital. We also tend, if able, to put people in with their own doctor for continuity of care. We also found during this COVID that we've had people off work, GPs off work, and our nurses as well, who can carry on, if they're well enough, doing clinical triage at home. And it makes me think in the future that there may well be a role if someone was to consolidate a number of PMS systems to allow people to do the triage almost as a job. They could be doing it for a number of practices at once from a remote location. Both our patients love it, and we as providers have found it something we enjoy doing, because it's freed up time and made the stress levels drop markedly. Mel's going to talk a little bit about bums on seat doesn't mean more money. The more people you see, the less your capitation is worth to you, and it doesn't always make sense to book people in just because you've got a spare appointment. As Northern, we get paid a little bit of money for our healthcare homes model work, so it's a requirement, although out of the 150 or so practices in New Zealand that are doing healthcare homes model of care, not all are paid, all are doing this as a requirement, but none of them have actually stopped doing it, because once you start doing it, you wonder what the hell you were doing before you did it. And so that, if you look at our model of care, you could start on the left-hand side where it's just not done at all, you don't do any triage, right through to doing it systematically throughout the day using someone who can diagnose, order investigations and prescribe, particularly at heaviest time of the day, and wherever possible, do continuity of care. And it keeps people happy and calm at home if you know that they can ring up any day of the week and be sorted out. Our patients have been at this long enough to know that that's all they do. They ring up and say, could someone give me a triage call back? And that's something they've got so used to, and are very happy to know that within half an hour, most of the time, they get called back and sorted. This is probably interesting for a northern sense, and that little blue dot actually was Mel's practice she managed in Tikibunga, and the orange and red dots are patients who had in a month's period had a triage call with her practice and had their problem resolved over the phone. If anyone knows what northern roads are like, which are often 2/3 of them are not sealed, and people's cars are quite often unreliable, and some of those dots are a good maybe hour's drive from the practice, so you're talking around a 2-hour return trip with half an hour waiting, and you can imagine how nice it feels to be sorted out in 3 minutes. maybe that's not a problem, but I imagine driving across Auckland in rush hour probably takes 2 hours as well. And the simple thing like doing triage, so this is a bit busy, but that's the model of care across all the domains and elements. But what I've circled there is just saying telephone assessment and triage. That block up here is all the acute care, and that actually all gets sorted by doing triage. So you reduce patients' wait time, you can give them same-day access and access during business hours. But also up in the top right, there's some stuff about routine and preventative care, and also in the bottom about business efficiency. It all gets sorted with a simple thing of doing triage. So across the practice, it does a whole lot of things to improve how the practice runs. So I said, patients enjoy it, we enjoy it. That was borne out by a bit of research we did in Northland a year after we got going with the first healthcare homes practices. That green you're looking at, the khaki green, is people's satisfaction with the elements of the model of care. And you can see administrative and receptive staff absolutely love triage. They have had their whole world improved by the fact when someone rings in and said, I want to come in today, they just have a standard script. They say, we have appointments today. One of our clinical staff will ring you back as soon as possible. What's your best phone number? And can you give me a bit of a heads up what's going on? And they put it into, I'll show you shortly the process, but they put it into the day book to get a call back. And quite often from what they know, that little brief conversation, they can work out whether it's likely to be a doctor call or someone else could handle. So things that require prescriptions or medical certificates, they'll put the doctor in front of it so we know to do it. Doctors like it, the managers like it, the nurses like it, people like it. Mel's going to talk about the maths, because the maths of it are good if you're running a business, so it's an efficient process. And the other thing, I guess, is not to wind you all up, but our friend Helen Parker, who was a champion in Midlands of setting up healthcare homes, often would say to people, are we passing the patient test with the things we do? Just the fact is, if you told your room full of your patients how you're currently doing things, if you're not doing either portal work or triage work, and ask them if they think it's reasonable to make them drive for 2 hours instead of sorting out in 3 minutes, I think you'd likely apologise and maybe see it from their point of view and do things differently. So I'm going to run you through quickly. Some of you may have seen this. This is just inside my medtech and what we would do. So this left-hand template is where we put the people that want to be called back. And then we got the right-hand template of a day book. Depending on the day of the week, there's an adequate number of book on the days to match historic acute demand. We at the practice now, because it has been so busy, have got a duty doctor saying people that are well, not no viral infection, but need to be seen that day, and also a red zone. So our capacity has been really fine-tuned because the fact that things are a bit chaos in the middle of winter. So when we see somebody, we open up an advanced form. This is probably available through most of your PHOs, and if not, Ken Leach, who runs Procon, can install this. Not particularly expensive at all, but it makes our workflow completely smooth and allows us to not have to put any data into the system. First thing, obviously, if you can't get through to people, which is unusual, we'd say, no, we couldn't get through. Most would say, yeah, we've got through, we've written the history. On the right top there, you'll see something about warnings and medications and classification. So we do look at that as a glance, and then we do what the outcome is. So you might have resolved it in triage. You might write a prescription. So you press that button, your script comes up, you okay that, you okay the box, back into medtech, finished. That's the whole process end to end. We charge patients normal prescription fees. We charge people medical certificates. It's important to actually say you're going to do that. I think we as doctors, nurses are sometimes a bit slack at talking about charges. Just need to say there will be a charge today for that prescription. I've yet to hear someone say, oh, that's not very good, considering it's been sorted out in 3 minutes and they've had their problem sorted. So that's one. And if we couldn't get through, if we can't sort it out with triage, we've got to say why. So let's say you've got to see a GP, they're going to see them face to face, they're going to see them today. That then writes back and it's back into medtech. Likewise, we might say they couldn't sort it out, they had to go in A&M or ED, but is that the right thing? So we've got an idea if it's an appropriate thing or the practice is busting at the seams, we had no capacity. And again, all that just writes back into medtech. So it's a very straightforward workflow. We don't deviate from just doing what we'd normally do as clinicians, not realizing and behind that's a lot of rich data has been collected. So that form I just showed you, you've just been trained on how to use the triage form, by the way. And that's it. You open up. We have locums or we have new people and they point, I say that's how you do it and they just go for it. We like, oops, sorry, doing that. So we like doing them. There's no additional data and we have a very lean process planning from that information how to make the practice run smoothly. And that's the train going back on the tracks. Inside that process of the advanced form, there's a way of just getting a report. Our report is put into Thalamus, and this is for a bush road. This is a pretty up-to-date report. So at the moment, doctors are triaging resolving 52% of all incoming calls, and a third of them are coming in that day. So we're able, half of all people we see with doctor calls are being resolved. We're doing most of the calls now because of COVID, and a lot of people are needing assessment because they're not well. But for all the patients, all the staff, because the nurses take over and we've got a paramedic doing it, and it's still running on average at 41% of all patients are resolved. That's a little skyscraper, and if you look at that, that's the number of calls that we are triaging per day at my practice. You'll see on the 4th of July, there's a little bit of skyscraper hits a new level. We had triaged 65 incoming calls in the first 2 hours of the day that day. Between 7:30 and 9:30, we had 65 calls. By the end of the day, we had 115. It was the first day in the last 7 years that we had a little spillover where we couldn't sort everyone out that day, and some of the people had to come in the following day. Up until that point, we had no day in memory where we hadn't been able to sort out every single patient that had run the practice wanted to be seen that day. One way or the other, the system worked well enough. We have no problems sorting out everyone seeking same-day care. So that's about on average. If you look across, this is right up till May, we're fielding around 1,000 calls from patients every month. And this information I'm showing you allows you to do some supply and demanding. So you can work out how many free appointments you need each day, how many call handlers you need to be able to do it efficiently. So that takes our daily temperature. It means that we can get our book on the day right, so we can get our doctor and nurse time right for doing triage management. We've probably got some fine tuning to do. We probably don't all standardly use the triage tool exactly in terms of when we open the window. So the timer, which measures the lengths of call, could probably be a little bit more accurate. And also, I guess, what one of us might think is urgent, someone else might not. We've got 3 categories, which is, urgent, not same day urgent, same day not urgent, or another day. And that probably could be looked at a little bit. There isn't any correct resolution rate. So some of our docs will resolve at 30%, some are resolving at 70%. We know that if you speak to your own patients, you resolve a lot better. And so for some small practices who may have even solo practices who took on triage, they would probably find that 70% of all the people they spoke to, they could sort out rather than have them come in. And often sort of envious of that, thinking how well you'd do if you were just doing this for your own patients. We probably have some champions that do resolve well, and we tend to put them on for more time than some of the other staff. We are definitely got our supply and demand pretty finely tuned, and sometimes do wonder around the place whether this patient test is driving clinical practice. I do a lot of accreditation and certification for the collaboration, looking at other practices around the country. And it seems to me, unfortunately, that the biggest driver for resolution is how many same-day appointments people have. Places with lots of capacity don't seem to want to resolve. It's just it's human nature. I think people go, well, it's easy just to come in and that's that. If you're working in Northland, where it's somewhat of a train wreck, it certainly tightens your focus on putting the patient first, because if you put the patient first, you always help yourself no end.
Okay.
Mel thought it'd be useful just to talk about portals as well, because that's another way we
Yep.
are dealing with acute demand. Quite a lot of the things that we receive through the portal, you know, although there's a 3-day turnaround, save people coming in or ringing the practice. And again, if you look at that last thing I showed you, if you look at a functioning portal, does all those things inside your practice and those as well. So just those two things I've shown you do a massive amount of good to the way you run your practice. And so from a point of view, when you're looking at demand and stretched workforce, having another channel does aid the practice in managing their workload. Lets patients self-manage to a degree because they can see a lot of their own records and a lot of their own results and order up medications, and gives them another way to get hold of us that isn't so pressured and allows us to do some of that work at a time that isn't so difficult for us. So this is Bush Road data. We've had patients enrolling now for the last 7 years into our portal. We open notes. All our patients on the day in April when they got going with it could read their notes for the previous year. If someone signs up for the portal today at Bush Road, no knowledge that they'll do it in July of 2022, they get their notes back to April 2014. They can read 8 years of notes, yet to have a complaint from any patient regarding the quality of the notes. And most patients appreciate the fact that they can see their notes. Very useful to then reflect on what happened in the consultation. There was quite a lot said, because I think people often slightly overwhelmed sometimes with the amount of stuff we ask them to do. So you got 56% of our patients over 16 on the portal. A few haven't been activated, and we're thinking of getting some good public Wi-Fi to activate them on the spot. A lot of work comes through it. So we had 15,000 incoming messages from patients last year and almost 20,000 sent out by staff. You add that to our close to 12,000 triage calls a year, and we're almost doubling our face-to-face appointments. The amount of times we're dealing with patients has doubled. We sometimes feel a bit swamped by all those messages coming in, but they'd come in one way or the other. So if you were to do that, there'll be people ringing and there'll be tasks set and bits of paper floating around and one staff member talking to another. And I don't think there's any more efficient way of doing it. It's extra work. It does seem like a lot of work, and you said, we've almost doubled our patient contacts, but it's work that's really happening. We're not making it. This is demand that's really there, and we've got to do what we can to resolve that demand. Also do 5,000 prescriptions through the portal last year. So there are some things that are a reality with portals, and that is that we are, as doctors, like to get a bit more work from them. It's work that's going to happen one way or the other. Someone's going to ask you to do this, say with a bit of paper or a task. So we need to, I guess, dare I say, suck it up somewhat. We set aside some virtual time. So one of our doctors who gets a lot of messages has got half an hour a day set aside to catch up with his portal volume of work. This should not be additional work. If possible, it should be set into the day. The out of office functionality is really clunky inside our version, which is managing my health. So it's you can't turn it off when you go on leave very easily, or even turn it off over a weekend, so that you aren't getting sort of slightly swamped. We're pretty careful at setting up rules of engagement to actually train patients about what the portal is and what it isn't. So if someone uses it for something we don't think is quite right, like saying, I've got a UTI, I need some treatment today, I anyway will often say to that person by the portal, you'll need to ring back on triage. There's a 72-hour turnaround for portal messages. That's the way we do it. This isn't for urgent work. I don't actually sort it out for them, because I believe if I sorted them out, then they'd go, well, it worked last time, I'll use that again. Likewise with prescriptions, I'll go, your prescriptions are on your long-term medications, you'll need to order those up on the portal. And it seems a bit mean maybe, but in fact, that etiquette or that controlling how people do behave on it makes a difference to how swamped you can feel by it. I don't do any consulting on it. The message inside the system said message my GP or message my nurse. I say to people, I don't want messages longer than a text message. It's just the way it seems to work better that way. There are some people that use it quite a bit. They're actually not your worries quite often. They're people that just happen to be, that's their mode of communication. So they like doing it. So I don't do any long threads. If I've got a backwards and forwards going, I just say I can't do justice as 5 messages. We'll need to have a telephone, video, or face-to-face consult. It's really great to be able to correspond, I think, directly with the patients. I mean, you get results and you can explain exactly what you want them to know. It's personal and it's, I think it's highly efficient. So that's it, Mel. Let's stop the sharing.
Thank you so very much.
We'll field questions at the end, no?
Thank you, Andrew. Yes, we have got some questions coming in on the chat. Thank you very much. What I'm going to do is let Iain take us through his side of the experience of clinical triage and managing acute demand from West End's point of view, and then we'll rattle through mine really quickly, or perhaps pause at that point because mine is the least important, and it's great to give people a chance to do some kōrero as well. But I'll pass on to Iain now. Here you go.
Oh, hi. So yeah, I'm Iain Watkins, at West End Medical Centre. I don't have any slides. Mine is a narrative, really. I just want to talk through our experience as a small practice with using triage. We first used triage before we were even enabled healthcare home. We went to a talk by Midlands up at Maitahi one evening. My wife and I, she's the clinical director at the practice and co-owner. And after we walked out of there, we said, oh my God, there's so much good stuff here, why wait? So the first thing we took on board was triage and huddle, which we thought they sound really great. And we took that on board and started doing our triage following the huddle. Then we got invited to put in an application to be part of neighbourhood healthcare homes, and in 2016 got into the first trounce of the 4 practices that were selected for the first run at it here in Te Tautokoroa, and developed from there. So I just want to go through our journey and the things that worked and the things that didn't work for us along the way, and then what does triage look like for us today. Being a small practice with limited amount of doctors, we've tried to emulate Bush Road and do all day triaging, but I'll come back to that one later. It worked and then it didn't. So generally, we entered into neighbourhood healthcare homes and took on all the bits and pieces, the portals and that. We operate through a call centre, and so they're the first port of call for people ringing in for requests for same-day appointments. What we learned in the early days were the success of the triage depends on the staff member doing the triage. You can have staff members that are incredibly risk averse, and you may as well not be doing triage because they just bring everyone in. And you get that back, and Andrew showed you the data reports that we get back again, so we can see there those staff members that are risk averse. So like Bush Road, we then tended to use staff members that were better at doing triage. It was their jam. They could do it and do it well. We found that nurses were a bit more risk adverse than doctors, so also had a slightly higher rate of bringing people in and not actually using phone or video triage. So, but we persevered with that and mainly had doctors doing triage. We picked our doctors that would do triage, and we only did it for Well, at the beginning, we were getting maybe 20 triage same day appointment calls a day before 9 o'clock in the morning. At 7:45, we have the huddle, and a part of the huddle is to go through our same day appointment people and allocate it out to doctors, trying to get it so that their own doctor had would triage their own patient. They know the patient, usually triage is a lot easier for them, and certainly if they get their own doctor, they tend to be resolved more out of coming into a face-to-face appointment. We found that it was a little bit higher with another doctor, although most of the patients know all of our doctors anyway. We don't use locums, so if we have to cover, we're covering always internally. So it's always our own core of doctors that they'll be dealing with. And then came COVID. Came along COVID, and that changed everything. Because then we were forced into more triage. And in a way, we could cope with more triage because our waiting room was closed. We didn't have people coming in. And so people started getting used to the fact that they would phone and they would ring and see the doctor, either through video or just through a phone consultation. And we still brought people in. We set up a red room, and if a person really needed to be seen face to face, full PPE in the red room, and they were seen on the same day for whatever it was. We found that during COVID, the actual requests for same day appointments and that really dropped off. And in particular, it dropped off with the over 65s. They were just so scared of leaving home in the early days during the initial lockdowns that they just didn't want to come even if they were unwell. And we found that once we were out of COVID, we had a really sick population because these elderly people just sat on things that really they shouldn't have sat on. And we tried to reach out to them and get them to call us if they needed it, but we didn't hear from that population during the initial lockdowns. And people who used telephone triage for the first time because they had to, because we were all in isolation, in lockdown, that they loved it. And they said that, you know, this was great. Gee, I didn't have to leave home. It was all fixed for me. You know, my script came to my door. Lovely. Yeah, lovely. Soon as COVID lockdown ended, they didn't want a bar of it. They wanted to put on their old rough sweatshirt and come in. I want to sit in front of a doctor. If I'm going to pay for 15 minutes, I want a doctor in front of me. And so we found that really, if you want triage to work properly, you really need to educate your population. You really need to get them to understand what triage is for, and it was for their benefit. Younger people tended to stick with it. It was a medium that they understood, so they like to use phone triage, video triage. Workers particularly liked it because it meant that they didn't need to leave the workplace to have a GP consultation. And so there were two groups that actually found it really useful. But a lot of people just wanted back again to face-to-face. They wanted their old sweatshirt back on that felt comfortable and something that they understood. So after COVID finished, we had an English doctor who suggested, why don't we try all-day triage? And he talked us through his experience with all-day triage, and we all thought that it sounded really good. So we started same-day triage, but it meant that you had a doctor who was triaging all day. And in a small practice, that's a big ask, because you're losing that doctor really for a day of seeing patients. Not about bums on seats and getting money in, but actually meeting the demand that there was there for patients. we had same-day appointment. We had 6 same-days appointments open per GP that was working. And on any one day, the best we could do was 3 GPs, 2 on a normal day, 1 on a bad day. And when you had 1, you could not do phone triage. Someone had to be seeing the patient. So it was difficult. Also, the doctors that were doing the full day triage, they found it soul destroying. And that's how they described it. It just was not fulfilling for them to do the whole day. And by the end of the day, they were knackered. They were really tired. So we did some tweaking and some fine tuning, and we then made it so that one of our doctors did the morning, and then another one was rostered in the afternoon. The one that was rostered in the afternoon saw patients in the morning, one in the morning saw patients in the afternoon. So they had a mix of what they were doing. And that improved their well-being a bit, and they felt better about that, and it wasn't as draining to do half day of constant triaging for every call that came in. And this was every call that came into the medical centre was triaged, anyone wanting an appointment. Of course, we were still paying the call centre to transfer the calls through to us and do nothing, because we were the ones doing the triaging and making the appointments for them. But it certainly, it fell over the moment we lost one doctor. The moment we lost one doctor, we didn't have that clinical capacity to continue having one FTE a day doing the triaging. So we had to let it go. We just could not maintain it. And we went back to just our morning triaging. And so where we're at now is that really the first step in triaging occurs at the call centre. When someone rings in to get a same-day appointment or an appointment at all, the call centre will offer them a telephone consultation, a video consultation, or a face-to-face. Now, that allows us then to put, we get a good percentage now, because more and more, the longer we've been at it, the more our patients understand, the telephone consultation, and the more positive experience they have with it, the more that they actually use it. So we have them, first of all, flow the patients through so that the video telephone consultations are in our procedure on our appointment pad, and the doctor can see what type of appointment that they've got coming up. Those that demand a face-to-face, they go on, if it's before 8:45 in the morning, they go onto the doctor triage list, and they are triaged at the huddle, where we go through, we allocate a doctor to do the follow-up. We may pass it on to a nurse if it's just information required. As one of Andrew's slides showed, people's demand for same-day appointment, what they feel is important, may not be clinically important, but to them it is important. So our nurses will pick up a lot, and then some where the doctors say, look, just looking at the information here, because the call centre always asks someone the reason for their visit. And we had to do some education around that, because people were very, don't like being asked the reason for their visit. They don't. Once you explain it to them, they see the reason that you're asking, and then they're more open to giving that information. But certainly we can look at the information that we receive, and sometimes the doctor will look at it and go, no, that has to come in. We don't even have to triage that. They just need an appointment and they need it today. So that actually goes to our receptionist. And our receptionist then call the patient and just say, look, the doctor thinks you need to come in. Yes, we've got an appointment for you. Here's your appointment. Then anyone that rings in while we're in huddle between 8:45 and 9 o'clock, that goes on to nurse triage. So after we break away from huddle, the doctors go off to their rooms and they deal with the whoever's on their list to get a phone call back from that particular doctor. When we, as I said, before COVID, we were getting about, we were getting between 15 and 20 calls before 8:45 in the morning. That was on the triage list. I used to keep a tab of it because I wanted to know, was there any particular pattern in a week to triage calling? Was there sort of one day that seemed to get more than any others? Monday was always a busy day after the weekend for people wanting things fixed up. So that was always a high day. But now if we get 7 calls before 8:45, that's a busy day. We call that, well, our doctors call it a busy day now. Today we had 4. 2 days ago we had nothing. No one had rung in for a same day appointment that morning. And so anyway, after 9 o'clock, the nurses then take over from 9 to 9:30, doing any calls that come in at that time. After 9:30, if a person is requesting a same-day appointment, they will be passed through to the nurse, but our call centre has open slather on any open appointments after that. So they can't use the same-day greyed-out appointments, but they have open, they can put people in. So generally, we can deal with all of the people needing same-day appointments, and even deal with just general calls and bringing them in for on the same day. Now, yes, so that works quite well, as I said, depending on the staff member doing it, it works really well. So the pros for it is that it gives the GPs a feeling of greater control over the day. And it allows us within the huddle to allocate work and to also make sure that that person, where possible, is seeing their own GP. All of our patients know, because of the nature of GPs and practices, none of our GPs work full time. So they know the days to ring to get their GP, and they know that if they ring on a day their GP isn't working, which is well advertised to them, that they will see another GP on that day. And most of them are okay with that because, again, it's sort of managing expectation by making it very clear to them that if they ring on a day their doctor isn't there, then we'll put them in with someone else. But if it's urgent, they need to see a doctor, we'll get them into a doctor. And they're mostly all in agreement with that. We find quite a few of the morning triage calls are resolved in the call, and the person doesn't need to come in. In fact, generally, we've already identified those that need to come in because of the nature of the reason that they're wanting to make an appointment. So generally, when the doctors go out and do their triage calls of what is left, those are ones that can be resolved. They just want a script, they want a medical cert or something like that. And especially if it's their own doctor doing it, that doctor has more confidence to provide some of those things without needing to bring them in face to face. And I notice that now that WINS and ACC now have made it that we don't have to do face-to-face to do their certificates. They're finally catching up with the modern age. The cons of it are if you have limited doctors, like in a small practice, you can get a day where it's very hard to do a triage. In the last week, I gave 2 doctors the school holidays off because they had young children, which left me 2 doctors on. And in the first week of the school holidays, one of those doctors got COVID. And in the second week of the school holiday, the other one got the flu. So we had 1 doctor left to actually operate in those 2 weeks. And for that, we could not, we could do minimal triage at that time. That 1 doctor could only do a certain amount of triage, because you need a certain, it's almost like you need a certain critical mass of doctors to be able to do it 100%. To be honest, we would not be able to do it without the funding. The loss of income in downtime is quite major. We get $6,000 a month to do the neighbourhood healthcare homes. Our call centre costs $4,300. So the funding that we get does not totally cover our outgoing to provide neighbourhood healthcare homes, but we're committed to providing the components of neighbourhood healthcare homes because it just works so well. Our doctors are happier. They feel more in control. They feel like they've got, instead of being proactive, instead of being reactive during the day, they're now being proactive during the day. They're getting, it's not just sitting in a room and waiting for the next person to come in and what's the surprise. They actually know what's coming in because they've organised most of it. And for them, that makes them feel a lot better in terms of that. They feel like coming to work again, which is a common thing that doctors that work in neighbourhood healthcare homes practices say. They actually enjoy it again, being there. And part of that is that proactive nature of it and the proactive control that they have by using a triage process. We would like to go back to all-day triage, but as I said, as a small practice, it takes one of your doctors out a day, and a small practice that doesn't work. But if you can do the core, if you can do the morning triages, use your nurses to then triage once the doctors are in their face-to-faces or calls or that, then that works really well. And patients who are used to our system know that they'll get a GP at a certain time, but after that they'll get a nurse, and then after that they'll just get into it. We get people ringing up for a same-day urgent BP and things like that. So it's easy to deal with those patients. We get the same data that Andrew was showing, and that allows us then to sort of give feedback back to the staff on how the triage is working and how it's working for them. So that was our journey. So we started off with the basic triage. We went, COVID forced us to expand. We thought we'd go even larger than that after COVID, but that did not work and we had to pull back from that. And now we're back to the core triaging first thing in the morning for same-day appointments.
Thank you so much, Ian.
Yeah.
Hey, I'm mindful of time and there are lots of questions, but I'm wondering if I can cunningly share my screen and address some of those questions in my section. So I'm going to try and do this very quickly so that there is also a bit of time for kōrero with our speakers later. I've just got a list of the questions here. So really pushing through this quite quickly, I've put up a couple of pictures here of flow, and this is the old way where patients called us and the question is, who decides who gets that same day appointment? And in the old world, it was reception and or patient. And I've also put up some slides, which of course we'll send you, which address the cost of it. I'm making the point that I've put up a generic capitation formula there, but if you acknowledge that it's somewhere around just under $200 per year, and if our GPs are costing anything from $75 to $85 per 15 minutes, with overheads, once you've had a number of consults with a GP, then you're actually losing money per consult. And this really makes the point that overutilization per patient, or dilution, the word Andrew used, of capitation, happens over time if you know, if it's the same patient sees the GP. This is a flow diagram of, you know, sitting in what we would call modern practice or the healthcare home. And I've put the patient portal in there, and I've put the phone with a big yellow thing saying clinical triage. And both Andrew and Iain have talked through the model where, from a patient point of view, when I call the practice, the phone is answered. That is actually the first part of it. And then from there, if it's the same day, if I need an urgent appointment, I will get a call back from a prescriber, is the language I would use, and it'll become clear as to why in a minute. And emerging post-COVID, of course, I could have a same day in-person or digital appointment as well as a routine, and those decisions are made in that clinical triage call. And I think it's also good to acknowledge that our workforce is getting wider, and I think Andrew and Iain both made the point that that patient may need somebody else. They might need a HIP or a health coach, or, you know, a different appointment with a different modality. You've seen some of this data. Clearly, we won't be able to answer all our calls if we don't know how many we're getting. So actually getting the data is important. Typically, certainly in Tai Tokoro, and I know across the country from Collaborative Aotearoa collects this data, 30 to 50% resolution for clinical triage. In other words, the reason why I used the word prescriber is if the patient receives a callback from a prescriber, 30 to 50% will be resolved on the phone. And that's because we know that quite a few of those are repeat prescriptions. And Andrew talked to the numbers. This is Tiki Ponga, you know, 75, 80 calls in a morning on a Monday. COVID pushed demand levels up and down, so it made it much harder to manage, exactly as Iain said. In bigger practices, we were doing things like having remote GPs who could support triage, using pharmacists to pick up the repeat prescriptions if everybody was sick. I think the thing is that with clinical triage, you have all your urgent calls in one place, which you can manage virtually, and that's very helpful. Some data there on minutes managed on the phone. I'm just going to pick up some of these questions. There was do we charge for resolved calls? And typically, for example, if a prescription is raised, that's right, the patient would receive a charge for that. If, for example, a WIN certificate was renewed by phone, that would also be a consult charge. In other words, would I have done this in an in-person consult before? Is it resolved? Then that results in a charge. If it's not resolved, clearly then it's, you know, we're not going to charge for what was essentially an assessment or screening call. There was a point made about GPs versus nurses, and I hope I've picked that up, because the 30 to 50% resolution is if you're a prescriber. Do you ever have any patients who you would always bring in? We might bring that one back. And some people talked about using different roles to pull inappropriate calls off the triage list, and that's exactly right. I am going to we've got 5 more minutes open up so that people can ask some further questions. And I'm just having a little look at the chat. There's a question here, maybe I'll put this to Andrew and Iain, are the call centre clinical staff?
No.
No, so Bush Road, we have our calls answered in-house by our call handlers, and they pass on anyone seeking an urgent or same day appointment onto that template, which is then run back by some of our clinical staff. So we have an in-house call handlers, our reception staff, and they deal with all incoming calls.
Yeah, at the call centre, no, they're not clinical staff, but they have very, very strict protocols that we wrote for them, and scripts that they must follow. The one thing about having a call centre, I think it was Chris's, Mel's sidekick, Chris, came in one day to evaluate us when we were in the early stages of neighbourhood healthcare homes, and Chris just happened to be a patient of ours, and he brought his son in, and he was sitting in the waiting room, and he just was sort of looking around rather confused, and he came to see me and he said, "I can't hear telephones ringing." And I said, "No, you'll never hear a telephone ring here." And so that just that volume of calls, that was the phone just constantly going, gave us two benefits. One thing is the whole stress level in the building for both the staff and the patients reduced, because there was this lovely calm silence. It also meant that our reception staff could focus on greeting and exiting patients without having to stop to pick up the phone and be dealing with people wanting appointments and stuff like that. So that was all round better. But no, they're not clinical, but they're highly controlled, and they follow very, very strict protocols.
Any more questions from anyone? Okay, so this last few slides of mine were around continuing to iteratively improve, and I think both our speakers have told that story well. So that's perfect timing. I just have to say thank you once again, Ngā mihi nui to Ian and Andrew, and to all of you. And I will close us with a closing karakia. Kia horo te marino, kia whakapapa paunamu te moana, kia tere te ka rohi rohi, I mua I te haurahi. Thank you so much. Have a wonderful rest of the evening. I really hope that was useful to you. And I've just mentioned in the chat, please email us on the admin collab email if you've got more questions or looking for some resources, or, we're happy to put more of these webinars on. Ka kite.